It's sure great to be here tonight, and thank you for taking time out of your schedule, logging in from where we're at across the county or the state or the country. We're glad to have you. For lack of a better title, I called this lecture Glaucoma and All of Us, meaning it's a chance for all of us as providers and patients, friends and family, those who might have glaucoma, to have come a virtual discussion and talk a little bit more about the condition, ways we can treat it, ways we can understand it better, and ways we can all do better with it. It's really an honor to be a part of the great group at Center for Sight, and I'll be part of work with Dr. Befrus, and I want to thank him and Danielle for helping to bring us together for this Zoom conference. What I thought we could do is, for a brief period, I'll just give a brief overview about glaucoma, and hopefully that'll generate some good questions where we can not have to listen to me talk. We can hear some of your questions and go from there. But really grateful you guys have all joined in. We sure appreciate it. I'll go and get started, and this is in commemoration and recognition of World Glaucoma Week. So just some backstory, some context. Our goal for this week is to increase awareness on two different levels. One is of providers and one is for patients. So last night, our practice held a provider conference where we talked with different local providers, many of you are eye doctors in the area. And we talked about glaucoma and how we can become more aware, maybe catch it earlier, diagnose it better, improve adherence, things like that. Tonight, we want to focus on you as patients and perhaps increase patient awareness and understanding. We feel that if we all understand it better, we all do better. So hopefully it'll be worth your time. Again, glad you joined in, grateful you've joined in. We'll kind of go from there. It's part of this World Glaucoma Initiative, as you saw there. And this is just one of their handouts. I just wanted to briefly kind of show what we're looking at about glaucoma. I think it's important numbers here that in the United States, worldwide, there's almost 80 million people have glaucoma. In the United States, it's about just over 3 million. But these numbers are projected to rise. So by 2040, almost 112 million, as you can see there. So that's important for us to make sure we're more aware of it. We could diagnose it earlier. And there's a couple of concerns that we look for glaucoma. One is in this bottom corner. The problem with glaucoma is many times you can't feel it. Doesn't cause any significant symptoms until it's too late. So the challenge is to try to diagnose it earlier so we can have a better prognosis. And sometimes there's just this late presentation. There's advanced glaucoma at time of diagnosis, maybe a lack of knowledge or awareness of it. And our feeling is if we can have an earlier diagnosis, we have a better prognosis. And I know a lot of you know a lot about glaucoma with that. So I wanted to kind of give a spectrum of the condition. On the far left, we have what we call patient with a normal, healthy eye, no glaucoma. And sometimes you may have heard the term glaucoma suspect. And these are patients who have some certain factors that make us suspicious for glaucoma. As we continue down the spectrum, if left untreated, these patients could advance to early glaucoma, moderate, or advanced glaucoma, end-stage glaucoma, where there is significant vision loss that's irreversible. Proportion-wise, fortunately, advanced glaucoma is relatively less common compared to earlier conditions. I'd say majority of our patients are more glaucoma suspect or early glaucoma, more moderate, and then some advanced. Our goal is, of course, as providers, to catch and diagnose glaucoma earlier here. If we can catch it earlier, we have better prognosis here. If we can treat it better here, we can prevent progression there. Sometimes, for whatever reasons, we diagnose glaucoma a little bit later, so we still treat it aggressively to prevent further vision loss. So how does glaucoma look? What does it look like? I think a couple of questions. If you look on the internet and do a Google search and find out what does glaucoma look like, what do patients see, some images like this might pop up where a patient has normal vision, and you remember that spectrum of early glaucoma and advanced glaucoma. And so the internet gives the impression that perhaps it's a constriction of our vision, a tunnel vision. And unfortunately, that's not the case. There have been several studies that talked about, well, what do patients with glaucoma see? And I think I see a lot of our great patients here online already. And you might ask yourself too, how does it affect your vision? And a lot of times it's not this dark tunnel like it's described online or perhaps described in different settings. So that's not the best definition. It actually, to kind of paraphrase an article from Crabb and Glenn and Garwa Heath down the bottom there, this is something I saw not too long ago. I was backing up my car and it had rained that day, so my rear view camera had rain droplets on it. And as I looked at it, that's exactly what the studies have shown that glaucoma is like. I mean, we have some clear spots, but most patients with glaucoma might have some dim spots or maybe some missing spots. You can still see it, but it just might not be as clear. There's maybe less contrast, more dim spots, or some missing spots. So that's one challenge for diagnosing glaucoma, that many times we might not be able to tell a big difference with our vision until it's significant in a setting like that. So I think one thing that we can do as providers, and also for those who have glaucoma, just to be aware of our symptoms, of what it actually looks like from a lot of studies and what patients tell us, and also to help educate your own family and friends that if you have glaucoma, even if they have so-called good vision, they might be seeing pretty well, it's still important to have their eyes checked for glaucoma because they're at slightly higher risk for developing it. So this is more how it looks rather than a dark tunnel, which is sometimes how it's inaccurately depicted online. And who is at risk for glaucoma? Well, there's several factors that can make a patient more at risk for glaucoma. And it can range from the single greatest modifiable risk factor, IOP, or intraocular pressure. A family history, especially with first-degree relatives, can do it. There's the term thinner corneal thickness. So the cornea is the front part of our eye. Sometimes I found that the cornea is thinner than that. That may be a risk factor. Partly because it might underestimate the true eye pressure, or maybe the overall structural strength of the optic nerve. Race can be a factor, especially more African Americans, Hispanic race. As we get older, that can be a risk factor. Many times the natural drain pathway of the eye just doesn't work as well. And as a result, the pressures get a little bit higher, leading to a situation up here like that. Sometimes being nearsighted can be a risk factor. In fact, the more nearsighted we are, can be a concern. So sometimes patients who've had LASIK, for example, they might not, or cataract surgery, they might not be nearsighted per se anymore, but their eyes are still in that situation. So we still watch for patients like that who are nearsighted. And there's health conditions like diabetes, and to some thought high blood pressure, hypertension can do it as well. So there's different risk factors that we want to watch for in patients who might be suspicious for glaucoma. And this is what we call a glaucoma suspect. Many of you here I see are what we might call glaucoma suspects, where there's just a few risk factors that we watch for. And over a series of visits, maybe over a series of years, we try to determine what's your risk of developing glaucoma. Has there been any changes that we need to start treatment? So these are the who's at risk for glaucoma to consider. So with that said, of how does glaucoma look? Who's at risk for glaucoma? What is glaucoma? It's a great question to consider, and we hear it every day in the clinic. And I think we try to get better and better at how to describe it. I like to describe it as it's a condition or disease of the optic nerve. So here's a picture of a normal looking retina. And here's the optic nerve. There's circle shape here. Here's our macula. That's what we use for our center vision. These are the healthy blood vessels. And the optic nerve is kind of like, the optic nerve is what connects the eye to the brain. So imagine a really nice camera and a really nice computer and a cable that connects it. Well, the optic nerve is what connects our eyes to our brain. And if that cable or that connection is damaged or it's impaired, it won't send the signal as well or as clearly. So as a result, things seem dimmer. There might be some missing spots, just like we showed earlier. And sometimes it's hard to detect that damage until it's significant. So as providers, and this is why it's important to have an annual eye exam once we get in our 50s, for sure, we check for glaucoma. So this is a patient with glaucoma. It shows some certain characteristics. For our optic nerve, it should look similar to a donut with a round shape and a small depression and a nice, healthy, even rim all the way around. If we go to this slide, this is a patient with glaucoma. Again, it should look like a donut with a round shape. This rim up here looks really good. This rim looks good. But look at down here. See how this rim is looking thinner compared to other rims? Also, if you can see this little area here, that's what we call a disc hemorrhage, a little area of bleeding on the optic nerve that's pretty specific for glaucoma. It can be caused by other things, but if we see that in a patient who might be at risk for glaucoma, that raises our concern a little bit higher. So we have that disc hemorrhage, we watch for that. Also, we see that the rim is a little bit thinner and it's kind of sloping. These disc hemorrhages just last a few weeks, but it's nice that when we see that, gives us maybe some increases certainty for the diagnosis. So this is a patient with glaucoma, different than a patient with the normal looking optic nerve. And as providers, when we see patients, this is another patient, their eye. When we look at the optic nerve, I like to say, in my mind, I look at three things. I look first at the size of the optic nerve. We all have this, there's normal variation in the sizes of the nerve, normal overlap from small nerve or large nerves. This is more of an average size nerve. So look at the size of the nerve, and then I look at the size of the nerve all the way around where this white ring is. That's the size of the nerve. And then look at the rim with respect to that nerve. You can see how this rim appears thinner. This rim here looks pretty good. This rim here is a little bit thinner in some areas. It's kind of sloping. And glaucoma has preferential nerve damage. I mean, it usually affects the top part here and the bottom part there earlier and in early and moderate glaucoma. So as providers, we of course try to look in those areas to look for any signs of glaucoma damage. Another thing we look at is we look for disc hemorrhages like I showed in that last slide. Here's a small one there, there's one there. And these can be really hard to see in the clinical exam. Sometimes they're easier to see with photos. But in my mind, I like to have as a pertinent negative in the chart, there's no disc hemorrhages. I feel if I can look for them, I'm more likely to detect them. If we're not looking for them, we may miss them. So we look at the size of the nerve, we look at the disc hemorrhages, and we expand our vision, our analysis outward to look for any what we call nerve fibrillary defects. This optic nerve is composed of hundreds, thousands, even over 1 million fine smaller nerves. And if those are missing, if there's defects, that can be a sign of glaucoma too. So that's my 3-step approach to look at the optic nerve. This is why it's important when we dilate your eyes to look carefully at it. Those can be the early signs or clear signs of glaucoma. And in my mind, a good systematic evaluation of the optic nerve is the best way to diagnose glaucoma. As we look at that, so glaucoma is a condition that damages the optic nerve. These are some areas we look for. Well, fortunately, there's correlation, what we call structural correlation, how the optic nerve looks. We sometimes do what's called an OCT. Many of you have heard that before. It stands for optical coherence tomography. And basically, it uses light. It's like ultrasound, except it uses light to look at the optic nerve and it tries to find, are there any areas of the rim that the computer thinks are thin. So here's one here for the right eye. You can see that disc hemorrhage again. And if we look over here, there's correlating structural damage. It looks like up here, I don't see a disc hemorrhage, but it looks like it must be thinner. The computer thinks there's correlating structural damage up there. So OCT to providers is an important tool. It adds certainty to what we're looking at. At least every year, your provider will do an OCT to see if there's any computer estimated changes aside from your annual dilated eye exam to look for any clinical changes. When we have these changes here, it's important to also compare it functionally. How does it affect our vision? The way the eye works is if there's damage down here, which we see right here, then it affects our top vision up here. So I like to see, well, where's the damage? Does it correlate with a computer scan? If it correlates here, where would I expect to see it? And I'd look up in this area. So these dark spots are areas where the patient didn't see it as well as we would like. Now I know this last one is everyone's favorite test, the visual field test. In fact, people they just stand in line. They can't wait to do the visual field test. They love it so much. I'm sure that many of you are shaking your head, denial. I had a patient the other day, I told Dr. Beffers this, that after we did the visual field test, I said, thank you for doing that. You did a good job. It helps us detect functional damage in glaucoma. And he just sat back and said, Doc, it gives me the blues. So he really didn't like the visual field test. We understand it's not the funnest test, the most enjoyable test, but it sure is an important test because it helps us look for a functional correlation when there's structural damage. And I like to say it's a way for you and I to put down paper what you're seeing and how what you're seeing, and that can help guide our treatment. So there's structural damage, there's functional damage, and it's a condition that damages the optic nerve. So even though these visual fields might give us the blues, they're important to do. So we appreciate doing those for sure. So how do we treat glaucoma? By analogy and by symbols, here's kind of what we do. We try to download the data. So either they're pictures or OCTs or visual fields. And for each patient, that might be several times in a year. It might be a few times in several years, depending on their risk level, where they're at of that spectrum. We download the data. We try to put together the pieces. Are these reliable pieces? Does it make sense? Then we talk to the patient and find out, well, what's the benefit of treatment versus the risk of just watching it? And sometimes we can just watch a patient carefully, cautiously, without treatment. Sometimes we see that because of the amount of glaucoma or where it's affecting the center vision, we need to go ahead and start treatment. And then after talking with the patient and discussing these findings, we develop a plan, a mutual plan, where we try to identify the best route, best treatment to lower the eye pressure. The best way to treat glaucoma is to lower the eye pressure. And that can mean by doing it with eye drops, like Latempros, for example, drops you maybe take once a day or twice a day. It can mean using laser, which we can do in the office. We can even do implantable medication. Sometimes Dr. Beffers will recommend, or he'll do a surgery in the surgery center, which helps lower the eye pressure. So there's different ways that we can lower the eye pressure to treat glaucoma. After we have all that agreed upon plan, then we push start, we activate. We go ahead and proceed with the plan. But here's the important thing, that every time we see you, we always want to reevaluate and see if there's any changes that we should make as providers and patients to make sure we're doing the best we can to keep your eye pressures as low as we can, to preserve your vision as long as we can. The goal with the treatment is to preserve your vision as long as you need it. So we just want to make sure that we're doing everything we can for that process. And I think the best thing to do is what many of you already do, as you're with Dr. Beffers or myself or your local eye care provider, just to ask them what the best options are and what are the advantages of this or what are the disadvantages. I think a great question is, what would you do? That's often a helpful question for each of us as we kind of consider the different options. But we treat glaucoma, and I like to consider it as an analogy, kind of like this. Several years ago, if you wanted a soda, you had one Coca-Cola, so you really didn't have any options. So you had limited options for your drink there. Then as time went on, maybe we got some more options, different brands, different selection. And now, if you go to any restaurant, you'll see something like this with literally hundreds of options, different ways to treat, to get your drinks. Similarly, in the past, we just had maybe one or two types of glaucoma drops. Then we had different classes of glaucoma drops and even some types of surgeries. Now we have eye drops, we have lasers, we have surgeries, minimally invasive surgeries, more advanced surgeries. But the nice thing is now we have some different options that weren't available to us in the past to treat glaucoma and to preserve the vision. And just as a disclaimer, I am not sponsored by Coca-Cola, just an analogy. But hopefully next time you get a drink at your restaurant, you'll think about this and the different options available. So to kind of summarize, and then we'd like to go to some questions. Here are some risk factors we talked about earlier. So a patient may be at risk for developing glaucoma if they have higher eye pressure. Having said that, there have been studies that have shown that 50% or more of patients, once they're diagnosed with glaucoma, had pressures in what we call the normal eye pressure range. So there's a normal eye pressure range of 12 to 21. However, patients can have eye pressures above that range and not have glaucoma. They can also have pressures within that normal range and still develop glaucoma. So we look at the eye pressures, but it's not our main factor. But higher the eye pressure, the greater risk of developing glaucoma. As we get older, as we talked about, that can be a risk factor, increased nearsightedness, decreased corneal thickness. If you've had any eye trauma or eye surgery, that's a possibility. Different medications like chronic steroid use can maybe cause higher eye pressure and race. And main thing is it can cause higher eye pressure. That's our main modifiable risk factor. When we combine that, if the pressure is too high for that particular patient, it can cause glaucoma damage. And glaucoma, as I mentioned, is a condition that damages the optic nerve, affects a signal from our eyes to our brain, makes it so it doesn't work as well. Things might seem dimmer or darker. We look for correlating and other structural tests like the OCT. And then we look for a functional correlation. And all these are important because we know that glaucoma can affect the quality of life. It may have decreased contrast, decreased peripheral vision. It might affect our reading, our mobility, walking around, maybe our activities, our social interaction, our exercise. So we really feel like if we can do everything we can to preserve vision in glaucoma, so we can improve the quality of life. That's our goal with that. Not only to preserve vision, but improve the quality of life. So those are some overview, a summary. I had a patient today ask some questions, which was great. I really appreciate this. And I thought we could just kind of start with these questions. And then if you have some questions, we'll go and pull up the chat and I'll do my best to answer it. I think maybe we'll have some other doctors online that they can help jump in for me as well to perhaps say it better. But here's 4 questions I received today in advance. So thank you for sending it out. I really appreciate it. First question, besides eye drops to control my eye pressure, what else can I do to improve or preserve my vision? That's a really great question. Very insightful. We talked about the purpose of treatment for glaucoma is to preserve your vision. The best way to preserve our vision is to lower the eye pressure. Now, there's other modifiable risk factors that might not be as significant as eye pressure, but we could still do. And the simple short answer is if it's good for the body, it's good for the eyes. So eating healthy, having a good balanced diet, maybe taking antioxidants, omega-3 fatty acid, fish oils, green leafy vegetables. Eating healthy helps. Those can be antioxidants, which have been shown to help maybe strengthen the optic nerve, protect it some. Some of them even help lower the eye pressure. Also, staying active, getting exercise, that helps increase blood pressure or blood perfusion to the optic nerve. So staying active is helpful. Staying well hydrated, using caffeine in moderation. Those things excessive caffeine can cause higher eye pressure. And making sure your blood pressure doesn't get too high or too low. So we talked about eye pressure. Well, there's also blood pressure. They're not directly related, but high eye pressure, high blood pressure, excuse me, or high or low blood pressure can also cause damage to the optic nerve and may affect an optic nerve that's already compromised. So making sure you have good control of your blood pressure, eating healthy, staying active, those are all good things you can do to help your optic nerve stay healthy. It helps the body, it helps the eyes. In addition to that, if we need to lower the eye pressures more, we can do sorts of other treatment like laser or medications in the office that we can actually inject. Kind of going along with that, thank you, Mike, for calling this in. He has a question: if being treated for glaucoma, can stability be maintained or will vision eventually deteriorate even if under a care plan? Good. So if being treated for glaucoma, can stability be maintained or will vision eventually deteriorate even under a care plan? So great question, Mike. And I would just say that it depends on the stage of the glaucoma, how advanced it is. Unfortunately, studies have shown that the glaucoma is diagnosed in later stages. There's more likelihood it could progress. So if it's diagnosed earlier, we have a better prognosis. If the treatment's sufficient, meaning if we make sure we lower the eye pressures enough, and if there's overall good health, that helps preserve the vision, helps keep the optic nerve healthy, prevents further progression. And if there's sufficient adherence, so it's a partnership. When we work together with patients, one of the most important things to do is if you're on medications, to make sure you take it every day. Studies have found over and over again that if we take our medicines every day to lower the eye pressure, for example, it keeps the pressures lower. So Mike, I'd say that if there's sufficient awareness in diagnosing glaucoma earlier, if there's sufficient treatment, and the pressures are low enough, and sufficient adherence, those are 3 things that we look for, that if we can make sure we're maximizing it, that will control the eye pressures and ideally keep the glaucoma from progressing. There's good prognosis for patients who are able to have the right treatment at the right time. So great question. Thank you for that. Another question back here: are there foods or treatments to improve my vision loss, my loss in vision acuity and field of view? Kind of referring earlier that if it's good for the body, it's good for the eyes. And there's a lot of research into regenerative and restorative treatments. There's some different medications or just different nutraceuticals, which are helpful, like ginkgo, and vitamin D is helpful. So you should just take a good multivitamin, eating healthy, staying active are the things that I recommend. The studies aren't as strong as we'd like them to be, so it's hard to say for sure, but it sure makes sense. If you can take a multivitamin and have the right balance of vitamins, those are all helpful to do. Another great question: can too low blood pressure in an 82-year-old woman make vision acuity or blurriness worse with glaucoma? This is another great question. I mentioned that eye pressures is one of the main modifiable risk factors. However, blood pressure can also affect the optic nerve. It affects what we call the perfusion. So that nerve needs blood supply to it. If the blood supply is too low, it doesn't get the perfusion that we need. Now, many times your doctor, primary care doctor, will ask about your blood pressure and be very pleased with this low blood pressure, which is good. We want low blood pressure. But if it's too low, we might not get the blood supply that we need to the optic nerve. And if it's already a compromised nerve, there's already been some glaucoma damage, it could cause it to get worse. So we want to make sure that it's not too low, especially that bottom number. Want to get a little bit higher. So one tip is if you take blood pressure medication, instead of taking it at nighttime, which is commonly done, try taking it in the morning time. At nighttime, our blood pressure dips already, it gets lower. And then if we take a blood pressure pill, it gets even lower. And so those are called dippers, nocturnal dippers. And we want to make sure we avoid those times when it's not getting the blood supply like it should. And similarly, can glaucoma increase likelihood of vein occlusions in the eye? What can I do to help prevent this? So the other end of blood pressure, there's low blood pressure, which can affect the perfusion. High blood pressure is also a concern. We don't want it to be too high. High blood pressure can also damage the optic nerve. In one way, it can cause vein occlusions. So central retinal vein or branch retinal vein occlusions can be due to high blood pressure. And that's actually a risk factor. This is a great question. There's a study that's done not too long ago that if someone has had a branch retinal vein occlusion or central retinal vein occlusion, they are at risk for developing glaucoma as well. So that's one of the risk factors I should have added to my list. That's a great point, to make sure that blood pressure doesn't get too high or too low. I hope I answered those questions well enough. Let's see what I have in the chat to see if I could have done any better with that. Let's see here, good. We'll go to the question and answer. Good. Okay. So those are great questions. What other questions do you have? You can pull the chat there. And I wonder if I can make it so I can unmute you guys if you want to do that too. I'm not sure on a webinar if I'm able to do that. I'm sorry, but let's see if I can do. Yeah, so I think at this point, if you want to just ask a question, I hope you would, that you go and just pull something on the question and answer period there and see what it shows. While you're thinking, I have a few questions for you, and then maybe you could respond in the chat on the Q&A for that as well. Let's see, let me pull this up here. So, as providers, we want to make sure we're doing the best we can to help you with your condition. So I had some questions for you, and you can send it in the chat or you can respond in the Q&A, whatever you want to do. But what worries you about glaucoma? How does glaucoma affect you and your quality of life? What things can we do differently for that? And related to that, how can we lessen the burden of the disease? We know that when someone's diagnosed as a glaucoma suspect or glaucoma, we know that it takes time out of your busy schedule. You have to leave work or leave home, leave family to come to work, have your eye pressures tested, the visual field done, your eyes dilated. Then there's the drop factor, have to take drops of medication regularly. Those are tough to do. There's the cost factor, side effects are related to that. As providers, how could we do better? And then the other one I'm always trying to do better at and figure out what are some barriers to taking your medications. You know, it's easy to take eye drops. In fact, they made it so easy where it's just once a day. It's almost too easy to take, too easy to forget. And it's hard to take medicine for a condition we can't feel when it's asymptomatic like that. So just some questions that I think about and try to do better at as a provider, along with the other local eye care providers and with Dr. Befrus. Good, so I have another question here. If you have asthma, are my steroids for treatment of asthma harmful for glaucoma? Great question. We talked about how medications can cause higher eye pressure, particularly steroids. And I just say the closer the steroid is to your eye, the more likely it is to cause higher eye pressure. So if it's an oral steroid or injection or inhaled, it's not as likely as if it's more topical around the eye, like a steroid cream or a topical steroid. The closer to the eye, the more likely it is to cause higher eye pressure. Now, not everyone is what we call a steroid responder. That means when they take the steroid, their pressures get higher. Not everyone's like that, but those who have diabetes, if you have a family history of glaucoma, that can be a risk factor. If you are yourself a glaucoma suspect, we'd want to be very careful for that. So if you find that you have to take the steroids a lot for a long period of time, or a lot for a short period of time, or a little bit for a long period of time, we'd want to have you make sure your eye pressures are checked and the optic nerve is carefully examined. So steroids can be a risk factor for it, and unfortunately, it's a condition that still happens a lot. It can be preventable if we can have that awareness of that. So great question. I'd still take your steroid treatment like your doctor prescribes for your asthma. However, if you're at risk for glaucoma, just have your eye care provider check your eye pressure and monitor it closely if you take it regularly. Great question. Thank you. Let's see if we have anything else there. Okay, great question. So is there any data to suggest a correlation between geography or where a person lives and glaucoma? I love it. You know, I think we're learning more about glaucoma, and there's still a lot that we don't know. There is a type of condition, a second type of secondary glaucoma. And I'll tell you what I mean by that. It's called pseudoexfoliation glaucoma. And basically the lens within the eye has this flaky material that comes off, and that lens within the eye, that flaky material has to go somewhere, so it clogs the drain within the eye. So I'm going to show you this, what I have here. Here's the picture of that, so I'll kind of lead into that. Here's the side view of the eye. So here's the eye right here, and we're going to take this image here and magnify it right here. So fluid has always been produced behind the iris, the color part of your eye. It goes up, and this fluid helps nourish the cornea, the inside part of the eye. And it goes down to the anterior chamber through what we call the trabecular meshwork, and is filtered out. Well, pseudoexfoliation is common in more Scandinavian, European countries. And that's where this front part of the lens has these flaky areas that come off, and they slowly clog the drain. And that clogged drain, like I mentioned, a clogged drain in your sink, the more there is, the more backup there is, and gradually the pressure gets backed up further and further. So pseudoexfoliation can relate to certain patients in Scandinavian countries like that. That's for open angle glaucoma. Also, there's a high prevalence of glaucoma in patients of Asian descent or Asian countries. Meaning there's open angle glaucoma, like we see here, and then meaning the angle is open. The other side is there's closed angle glaucoma. So here's primary open angle glaucoma where there's increased resistance because there's some blockage there for whatever reason. Maybe the drain's not working, maybe it's blocked due to pseudoexfoliation. And there's closed angle glaucoma where the iris, the color part of your eye, is moved forward, kind of billows forward there, and blocks the drain. So as fluid's being continually produced, it goes out here, but it can't go there, so it pushes everything back. And the fluid behind it just circles back around, pushes the iris forward, causes angle closure. This type of glaucoma is less common, but causes more vision damage. And it's more common in Asian countries, just maybe more nearsighted, shallower eyes. So great question about geography, demographics, and race. Thank you. Great questions, guys. I'm impressed. This is wonderful. Can the laser be done more than once if the pressure resumes an increased mode? Excellent. Yeah, so Jay, that's a great question. Let me kind of show what we have here. And there's two types of laser. There's a laser that targets this part here, the trabecular meshwork. That's called SLT, selective laser trabeculoplasty. And that's to help the natural drain pathway of the eye work better. And usually for most patients, it works pretty well. And if it does work, it usually lasts for 3 to 5 years. And which time, if it starts to wear off or the pressure starts to get higher, we can, in theory, repeat that laser for primary open-angle glaucoma, for selective laser trabeculoplasty. There's another type of laser we use for glaucoma, and that's where we put a dot right here in the pupil, in the iris, excuse me, in the iris. So you see how fluid circling around here, pushing the iris forward, blocking the drain. Well, we can do what's called a peripheral iridotomy, where we use a laser, make a little dot right there, and that restores the angle structure. I'm going to show you a couple of pictures about that I think is helpful. So this top angle, so this is what we call the trabecular meshwork. So as we look here, this is a trabecular meshwork. This is when we do gonioscopy. That's the drain pathway of the eye. That's where the fluid drains out. This is what we call an open angle. Open angle. In this patient, they have a closed angle. See, we can't see that drain, and it's blocked here. This is a side view. So what we do is we do a laser in that area, called a peripheral iridotomy. It takes just a few minutes. Doesn't affect your vision, doesn't hurt, can't see it. It just helps kind of restore this natural pathway. So then the iris goes back to its natural position. The angle opens up ideally, if it hasn't been like that for too long. And the doctor may see a small little spot here in the iris off to the side. Again, doesn't affect your vision, but it just helps restore that normal balance for you. So that's a great question. So it depends on the type of laser. This laser ideally doesn't need to be repeated, because once it's done, it's done. Sometimes it can close off, in which case we can do it again if we need to. But SLT for primary open angle glaucoma can be repeated every 3 to 5 years as needed to help increase and help the trabecular meshwork work better. I think SLT is a great option, and for the right candidate, it's a great way to lower the eye pressure so they don't have to depend on eye drops. Great question, thank you. How do you treat normal tension glaucoma? Wonderful question for the glaucoma there. And it brings up a good point. I talked earlier about, let's see here. For glaucoma, one of the main risk factors is higher eye pressures. And with higher eye pressures, it's an increased risk of developing glaucoma. However, some patients can have pressures in the normal range and still develop glaucoma. Having said that, the same way we treat higher pressure glaucoma is the same way we treat lower pressure glaucoma. We lower the eye pressures. And so every point reduction matters. Sometimes it's a little more challenging to lower the eye pressures when it's already kind of low. So we use certain medications that might work better in those situations for the same goal. Lower the eye pressures, either with eye drops or lasers, injections, or with surgery. The same goal for that. Sometimes normal tension glaucoma can affect more of our center vision, for example, compared to our side vision like other types of glaucoma. But each condition can affect the vision in different ways. The same goal is to lower the eye pressure. That's our only modifiable risk factor. The other thing to consider is for normal tension glaucoma, we feel like there might be more of a blood pressure component to it, meaning we can lower the eye pressure sufficiently, pretty well. However, if the blood pressure is also too low, there might be some more damage to that. So we really look closely with patients with normal tension glaucoma to make sure that the blood pressure isn't too low and we keep the eye pressures low. Hope that answers your question there, but the same way we treat high pressure glaucoma, we treat the normal tension glaucoma. Yeah, good question. It asked a question. I found that putting a warm washcloth, moist cloth on my eyelids each night and sometimes during the day has really helped my dry eyes. Will this also help prevent glaucoma by providing increased blood circulation? It's a good question, and a couple of things. Dry eyes, like glaucoma, is increasing in prevalence. And it's more common among patients with glaucoma, actually. So because our goal is to lower the eye pressure, many times we'll use eye drops to lower the eye pressure. Unfortunately, those eye drops cause dry eyes. They can wash away our good tears and make our eyes more dry. So we try to counteract that by using maybe preservative-free medications or different in-office procedures. So we try to treat the dry eyes with artificial tears or home therapy, in-office therapy as well. Both are important ways to do that. I'm not sure if heating along your eyelids to treat the dryness would necessarily improve the circulation. It's a great question. I don't think it'd hurt, but if it's good for the body, it's good for the eye. So I'd still recommend it's still good eyelid hygiene to remove that daily debris buildup to help with the underlying dryness. Yeah, great question. Let's see if I got everything there. Great questions. I really appreciate your involvement. I'm trying to see if I had any other slides that I think might be helpful for you. One thing we talked about a lot tonight is eye pressure, and I'll just share this with you quickly. There's so many things that can affect our eye pressure, similar to how blood pressure can fluctuate throughout the day, different time of day, different activities, different diets, foods, things like that. The eye pressure fluctuates too. And you might have an eye pressure visit with your eye doctor and the pressure is at a certain level one day, but you take it again and it's higher or it's lower. It might depend on the time of the day, but here are other things that can affect it. So intra-abdominal pressure. If they're checking your eye pressure and you're leaning forward or holding your breath, that can raise the eye pressure some. Also, age as we get older, that increases eye pressure. Head down positions can raise the eye pressure. So I talked about how important it is to stay active and exercise. However, prolonged head down positions, like in yoga positions, can also cause higher eye pressure. So if you have glaucoma, especially normal tension glaucoma, we'd want to limit those head down positions, try different yoga positions for that. Rapid fluid increases. So if you're drinking a lot of water really quickly in a short amount of time, they have found that can raise the eye pressure. In fact, that's sometimes a stress test. Some doctors say it might be helpful to identify patients with glaucoma. Sleep positioning. Sometimes if we favor one side, maybe right side or left side in sleeping, the side that we're on, we know the pressure rises a few more points. So that's why some patients might have glaucoma that might be asymmetrical. So trying to sleep flat, maybe with a little elevated, might help minimize the eye pressure difference there. Tight clothing. So this is a reason to not wear neckties. Tight ties can certainly cause higher eye pressure. And caffeine intake. I think they say 2 or 3 cups of coffee a day is sufficient, but if we drink too much caffeine, and especially too much time, that can raise the eye pressures as well. So in addition to using eye drops to lower the eye pressure, there are things that maybe we can modify in our lifestyle that might help with that too. Can't really modify age too much, so sorry about that. The other ones we might be able to affect some. So for intra-abdominal pressure, just making sure we try to stay healthy and active, and a good body mass index is helpful for that. As we discussed last night from our conference, Dr. Beffers reminded us of that. There's some things that can decrease eye pressure. So if we're dehydrated, that might do it. Also, alcohol and marijuana can do it as well. These are obviously not recommended treatments for sustained eye pressure reduction. So we don't prescribe that, of course, especially when there's more effective ways to do it without systemic side effects for as well. But those are things that can decrease eye pressure. I just want to show you that because there's so many things that can affect it. And we look at that as one of the factors that we can control, hopefully. Yeah, so next question is, can my Bipap apparatus affect the pressure? So, certainly, if there's increased pressure around the cheek area, or if there's increased what we call episcleral venous pressure, holding our breath or sustained holding breath like that, that can cause pressure around the eye. So the fluid inside the eye can't drain out as well. I'm not sure the Bipap machine necessarily would cause that. I haven't read that, but that's a great question. What I'm going to do is I'm writing down some of these questions you're asking. Give me some homework to go back and look it up. So when you see one of us again in your eye doctor, you can ask us about that. But that's a great question. If any other providers on here, I'd love to hear their thoughts on that too. Can a Bipap machine increase the eye pressure? Not that I know that's proven, but it makes sense. It's a great question. Thank you. Having said that, I think those Bipap machines are helpful to provide the oxygen and supply that we need. So we definitely need things like that. Again, it helps the body and helps the eye. Good. Let's see if I have any other questions here. There's different studies that talk about pressure, which I thought was helpful, how important it is, different types. Yeah, so we kind of talked about different types of lasers. So many good things to talk about, and really, I feel like we're learning together. As providers and as patients, we're learning together for that. So if there's any other questions we can help answer. Yeah, so I think in summary, kind of what we're looking for is we're trying to help identify risk factors. As we take those risk factors, we modify them the best we can, as safe as we can, as well as we can. We look carefully at the optic nerve and try to correlate with structural testing, see if there's any correlating and functional damage. And the best we can, working with the patient as partners in this care, we try to preserve that vision so it doesn't get worse. Unfortunately, once there's been damage done to the optic nerve structurally, or damage done to our side vision functionally, we can't get it back. What we can do is we can preserve that so it doesn't get worse. And that really is one of the neat things about glaucoma nowadays. We have treatment options where we can preserve it so it doesn't get worse. The key is to make sure we can diagnose it earlier. I think one of the best things that you can do as providers or as patients is when you have your annual eye exam, and when you're done with the eye exam, and before you step out of the room, ask your provider, doctor, do I have any signs of glaucoma? And what that does is it slows down the exam a little bit. The doctor thinks back and think, well, do I have any risk factors? How does the optic nerve look? Do I need to do any other tests to help diagnose and detect glaucoma earlier? So when you have your annual exams, wherever you are with your home eye care provider or whatever you're setting, ask your doctor that. You can share with me maybe a family history of glaucoma. They might want to watch a little bit closer. Earlier diagnosis gives us better prognosis. Thank you. I appreciate that you joining in like that. Good. Well, I really appreciate all you joining in tonight. I hope it's been helpful. I've learned a lot. It's fun to learn together. And as you find that there's more questions or comments, feel free to email Dr. Befrus or myself, or write them down so when you come in for your eye exam, whether it's with us or with your home eye care provider. Write them down. Let's talk about more. We'll learn more about glaucoma, and it's a way that we can help treat it. And there's a better prognosis, better than ever. So we appreciate your interest in doing this. Just the fact you're being here says a lot about who you are, that you want to learn more about it. And that's very commendable. So thank you so much for joining in.